Despite the excellent results of Dsaek surgery, visual outcomes can still vary considerably amongst patients. Recent evidence has linked grafts thinner than 130 microns to faster visual rehabilitation and better visual acuity. Commercially available microkeratome heads range from 130 microns to 400 microns. The heads with larger slits are not recommended to create ultra-thin grafts, as they produce a wide variation in cut thickness and hence pose a high risk of graft perforation. A single cut preparation cannot therefore be used to obtain ultra-thin Dsaek grafts. We have developed a two-step type of preparation consisting of an initial standardized debulking step and a subsequent refinement step. This can be performed in different ways, all of which have in common the use of microkeratome heads with narrow slits that minimizes the variability of the lamellar cut and practically eliminates the risk of perforation and tissue waste. If the donor tissue has a normal thickness of about 550 microns, the debulking is performed with the 300 micron microkeratome head. The anterior stroma is removed as per routine Dsaek surgery. Various methods can then be used to refine the resulting donor tissue, the thickness of which usually ranges between 100 and 200 microns. To be able to use the commercially available head with the narrowest slit, that is the 130 microns one, the debulked donor tissue must be artificially thickened. This can be achieved by soaking it for 24 hours in a hypoosmotic solution at the eye bank prior to shipment to the surgeon for the refinement step. Alternatively, BSS may be injected into the graft intraoperatively following the primary debulking. This is done by inserting a 30-gauge needle into the peripheral residual stroma and gently injecting the balancol solution. The injections may be performed at various sites in the periphery to achieve a uniform thickening. The hydration of the stroma bleaches the tissue, thus guiding the maneuver. The refinement dissection is carried out with a 130 micron head. The dissected lamella is unfolded and integrity of the tissue is checked. The donor tissue is then marked with a 9 mm ring marker to guide proper placement on the trephination block before being punched to size. The graft is extremely thin and a modified boozing glide is necessary to scoop it from the punch block to avoid improper manipulation. An ultra-thin graft flops over the side of the glide. In contrast to this, conventional Dsaek grafts are substantially thicker and hence do not fold over the edge of the glide. A bimanual pull-through technique is used to deliver the graft into the anterior chamber. Under continuous irrigation, the tissue unfolds spontaneously. Air is injected into the anterior chamber and the graft is placed into proper position. Unlike DMEC grafts, these thin grafts can be moved by ballotting on the corneal surface in much the same way as conventional Dsaek grafts. Finally, following airtight suturing of all wounds, a 30-gauge needle is inserted obliquely to achieve a complete air fill. An experimental study performed prior to the surgical trial had confirmed that ultra-thin grafts obtained with this technique were about half the thickness of those prepared with the conventional one-step method. Nevertheless, the refinement cut did not increase the endothelial cell loss. As an alternative to hydrating the tissue, new dedicated microkeratome heads with narrower slits can be used to perform the refinement step immediately after the initial debulking. To avoid perforation, the residual thickness is determined by means of ultrasound pachymetry. For a reading higher than 150 microns, a 90 micron head is used to perform the refinement step. Instead, when the residual thickness is below 150 microns, a 50 micron head is used. Here, a 50 micron head is advanced very slowly across a donor cornea directly after the use of the 300 micron head. The excised lamella is removed from the microkeratome and inspected next to the refined donor tissue to ensure integrity. When dissecting thin tissue with the microkeratome, it is critical to maintain a low pressure in the system in order to minimize tissue resistance against indentation, thus avoiding perforation. Empirically, the pressure is reduced in the system by opening the irrigation line to the bottle, which is placed at a height of 45 cm. The tube is then clamped at 40 cm from the artificial anterior chamber and kept so for the entire time of dissection. This case demonstrates how in the initial postoperative period the graft edge is faintly visible. As early as 1 month after surgery, the graft is now hardly visible even at high magnification during slit lamp examination. Only the beveled edge may be seen in the far periphery. The striking difference in lamellar thickness between conventional and ultra-thin Dsaek grafts is clearly visible on anterior segment OCT examination. The presence and contour of the ultra-thin graft can be fully appreciated only at higher magnification. In essence, microkeratome-assisted dissection is a feasible and reproducible method to obtain ultra-thin Dsaek grafts in a standardized fashion. These grafts retain the advantage of easy handling and delivery of conventional Dsaek grafts while holding the potential for improved visual outcomes of DMEK grafts.